practical pediatric endocrinology course is actually something which has been quite close to Grow Society, and we've been doing that for quite some time. We actually started off initially with the programs which were there in terms of the initial workshops, which started way back in 2010. We conducted around workshops across the country. In 2011, we had the first practical pediatric endocrine course, and Dr. Raghupati, Dr. Chaurasia, and Dr. Rashmi Kapoor, all three of them were part of that inaugural program as well. Subsequent to that, we realized that doing programs at the level of individual places, we started doing PPECs across the country, was very labor intense and was very difficult to manage, and a lot of logistic issues. So we thought of using the social media, the YouTube and the Facebook platform to spread knowledge about pediatric endocrinology. And from there, we realized that while videos are going to help out, we need something more concrete in terms of more information which is available. We started with the round fellowship programs, but how many fellows can you accommodate? 2 or 4 in a given time. If you want more people to learn, the best way was to go online. And in 2018, 3 years ago exactly, on this very date, we started MedEClasses, which is a learning platform. And this is really evolved now with multiple other factors happening in the form of books and mobile application to make it much easy in terms of overall aspects. So over the last 11 years or so, we have conducted multiple programs across the country. Over 10 PPECs have been conducted. There have been over approximately 8 modules which have been involved and implemented in around 100 workshops across the country. So a lot of people have interacted and really find friends across the country in that regard, which has been really helpful in that perspective. So as discussed, we started off with our online learning program. And this e-learning started off with the number of videos which are now available over the YouTube. And on last count, there have been 700,000 views from those videos, watch time of around 40,000 hours. So there's a huge amount of pediatric endocrine repository which is available, which is being accessed across the world. But as I discussed, that this is more like a non-systematic way. We therefore went ahead and started with our learning.growsociety.in to provide pediatric endocrine learning using validated tools and practical assessment. And we have got multiple courses. Till now, we are on 24 courses available. We've got special courses for postgraduates and fellows, providing specific needs using animated videos, lectures, and other information. We also conduct bi-weekly grand rounds. So every month we have got one for the postgraduates and one for the fellows. So it's free over Zoom. All of us should join. We already have around 700 people who are regular join these programs. And this is quite helpful from that perspective. As Sir was talking about, we had this basic pediatric endocrinology, and just recently, 3 months ago, we launched our advanced pediatric endocrinology, which is a 2-volume book related to every aspect of pediatric endocrinology. So entire course content is in these 1,000 pages, which are there in these 3 books. So these 1,000 pages, they are all online, as well as now we already made it offline as well, available for people. We always realize that the best way to practice is not really going through books, but to actually go from patient to the book and back. And therefore, we started developing these applications which make life much easier. So rather than going back and reading about DSD, you start off from the patient's point and then use that application approach pathway. So now the endocrinology app is by far the most resourceful endocrinology app on the web and the most downloaded one as well. It has got over 50 pathways, management, approach pathways, analytic tools. And over the next month, we're going to make a massive change in that, adding many new interpreters like puberty, DSD. So if you just put 4 inputs, you will get an output of DSD, output for puberty and obesity. I'm in pediatric endocrinology. This is a complete 3-year program, which is actually a hybrid program of both on-site and online over 4 weeks of visit, as well as online, as well as a diploma course in pediatric endocrinology for people who have got lesser times. Now, we all know that the most important hormone regulating the thyroid axis is actually the TRH, which regulates the secretion of TSH, which then controls the production of T4. Now, T4 is a pro-hormone. It does not cause its own effect. It is either activated via MDI1 to T3 or inactivated to a reverse T3. And this activation, inactivation really decides about how much thyroid is actually there in the body. Very importantly, the T4 and T3 are bound to the thyroxine binding globulin. So the free amount of hormones that we are seeing are actually the ones which are acting. but often we are measuring the total hormone. So there's always a confusion which happens in that regard. So it's always better to measure a free hormone. Now, when we have somebody who develops hypothyroidism, the first thing to happen would be that your thyroid hormones will go down. Your T4 will go down, but immediately TSH will go up. So the body will say, okay, let's get up the level, and T4 will become normal. So the first stage of subclinical hypothyroidism will be high TSH. The second stage will be low T4. The last will be low T3, because T3 levels will fall last, because body will compensate by increasing the MDI expression. That will cause more conversion in that perspective. So in hypothyroidism, T4 and TSH are important. T3 is the most useless investigation. Do not do T3 in that setting. On the other hand, if you have thyrotoxicosis, the first thing to go down will be TSH, if it's basically a primary one, which is the most common form. And the second thing to go up will be T3, because you have got more MDI activity, and therefore you can actually have normal FT4 and high T3. This is what is known as T3 toxicosis. So if you ask me which test to do T3, free T4 and TSH in somebody who has suspicions of thyrotoxicosis, suspicions of hypothyroidism, do a FT4 and TSH. On follow-up for primary hypothyroidism, TSH alone is good enough. On follow-up for central hypothyroidism, do FT4, TSH is useless. For thyrotoxicosis, do T3, FT4 and TSH on follow-up. Now, there's a lot of confusion as to which test to do, and I'll just summarize it very well. TSH has got a 40% diurnal variation, and there is also an interday variation. So when should we do it? Ideally, if you look at, the levels are lowest at the night time. So many people will say night will be a good time to do. But because 40% doesn't make a huge difference, the biological variation is 1,000 times. The range is 0.5 to 5. You can do TSH at any time of the day. Do not wait that, okay, somebody's come from a village 100 kilometers far off, come back tomorrow and we'll do TSH tomorrow. No, you can do the TSH right away. From that perspective, T4 again is important, because if you have taken the drug, the T4 levels will go up. So T4 is not, should ideally be done before the drug has been taken in the morning. So for T4 and FT4, do in the morning. TSH any time of the day can be done. And T3 is a useless test. The only indication of doing T3 is suspected T3 toxicosis. So that's what is to be done. So if you're talking about hypothyroidism, primary TSH should go up, T4 should go down, and T3 will be the last to fall. So do, for that perspective, T4 and TSH, and better would be free T4 and TSH, so that the TBG values are not affected. If you have thyrotoxicosis, TSH will go down, T4 will go up, and T3 will also go up more, as I discussed. So in that setting, you should do all three. And because there are a lot of variations in FT3 is a useless test. So never do FT3, do a total T3. This is how you should do in that perspective. Remember, dynamic changes happen at birth, because as soon as the child comes from a hot environment to a cold environment, there is a TRH surge, and there is a huge rise, and therefore different cutoffs have to be used at different age groups. And for that, ideally, you should do a cord blood sample for screening, or better, beyond 72 hours of life. If you're doing in between, you have to do a higher TSH cutoff, which should be used in that perspective. And we have given these cutoffs, so it's very easy to remember: 40, 20, and 10. So first week more than 40, second week more than 20, and then 10 would be a cutoff for treatment. For upper limit for consideration would be 20, 10, and 10. So use these cutoffs very importantly. A lot of people say that it's very difficult to assess, interpret. We can't remember so many values. Sometimes you give nanograms, sometimes you give picomoles. So that causes confusion. So you have to interpret thyroid functions appropriately. And in that regards, remember that always interpret in a fashion in which you have a combined level. So FT4 level and TSH should always be considered together. There is a log linear relationship between FT4 and TSH. If FT4 is low, TSH should be sky high. If FT4 is high, TSH should be 0. That's the basic principle. Now, if your FT4 is low, TSH should be high, above 20, and that's primary hypothyroidism. The biggest message I'm going to give in the slide is that if your FT4 is low and TSH is below 20, do not consider it primary hypothyroidism. 6 to 20 it will still be central hypothyroidism. And clearly, you need to be careful because then you don't want to miss your adrenal and cortisol deficiency. On the other hand, if the FT4 is high, TSH should really be low. That's basically thyrotoxicosis. If you have a detectable TSH adenoma, that's very, very rare in children. Forget about that. The big message is low FT4, TSH below 20. This is central hypothyroidism. Now, how to make sense of it? How to make it very easy? We've actually developed a thyroid interpreter which is going to come up very soon in our app. All you have to do is to select the age group, put the age, put the value, and you will get the output. So like in this case, it was borderline abnormal, but if the age becomes more from 3 days, you make it 16, automatically the value and output will come. So there are like 80 combination of results which are available, and this will give you a precise interpretation of the group. So if you look at this child who has a picomole value which is on the low for FT4, TSH is more than 20, all you have to do is to just suppress the button and you will see that this is primary hypothyroidism. But if the TSH was less than 20, let's say it was 15, you will immediately get a clue for central hypothyroidism. So this thyroid interpreter is going to be very, very easy in identifying and making diagnosis in that regard. So we'll start off with the first case. We've got Dr. Prateek, who is working as a consultant at Pediatric Endocrinology at our hospital. And please, Dr. Prateek, start off the case.
Thank you, sir. The first case is a 20-year-old girl. We have been asked for a reference from the NICU, and the doctor says that the TSH has come 28 in the newborn screening. So, Dr. Sonal, how should we proceed from here?
Yeah, good evening. As the TSH is, as Dr. Anurag already discussed, whenever because of the child is immediately born, because of the cold stress, the thyroid axis is activated and there is a surge in TSH value for the first, and it takes at least 48 to 72 hours to get normalized. So TSH, so first of all, TSH should not be done ideally in the first 3 days of life. And if at all, if you want to do the TSH test, you have to interpret it differently. So if the TSH cutoff value is more than 34, then you can think of starting the drug. But in that case also, the test should be repeated after 72 hours. So TSH 28 in first 3 days of life is not the, we should not start the antithyroid, we should not start the thyroxine. So this is the message.
Thank you, Dr. Sonal, for that.
Yeah. So screening should be done after 72 hours and TSH cutoff value is 34, if between 48 to 72 hours.
Thank you. Okay. Day 4-old child, on newborn screening, the TSH came 22. So the physician repeated the TSH on day 14 and it came down to 12. And again, on day 21, it came down to 9. The FT4 has been normal throughout. So, Dr. Seema, should we wait and watch? Can we keep repeating the TSH and wait for it to come down, or what should we do next?
Good evening and thank you, Dr. Prateek. As we have already discussed by our Dr. Anurag sir and previous speaker, TSH level for first 72 hours, the level at which we should act is more than 40. The etiology has been discussed why this is so. This is as per European Society of Pediatric and Adolescent Endocrinology. As per Indian Society of Pediatric and Adolescent Endocrinology, levels are given 34. And we should keep on repeating if we are not starting the treatment. As in our case, we repeat it after 2 weeks and levels are not dropping down. It is not dropping down. And the first week, we should act more than 40. In the second week, after the second week, we should act if the levels is not dropping appropriately. So if after 2 weeks, still the levels are high, more than 20 millinunits, we will treat, we'll start L-troxin, but the situation becomes dicey if the levels is not dropping down. After 3 weeks of life, after 2 weeks of life, level should be below 20. After 3 weeks, the level should be below 10 and normal value should be reached. So in our case, the level did not drop down to 6 milli units per liter. Hence, we evaluated the patient by doing nuclear scan and which came down to be hemiagenesis. So our patient required treatment in the form of L-troxin. So the key message, If the levels are high and we are repeating, the level should come down and we should always see the age appropriate level of TSH, 40, 20 and 10, first week, second week and third week of life. And if the levels are not dropping down to below 6 after 3 weeks of life, it needs further evaluation in the form of nuclear scan, thyroid ultrasound, and also at the same time, we should look at normal free T4 level and further treat accordingly. Thank you.
Thank you, Dr. Seema. So another neonate, a 10-day-old child, the TSH was very high at more than 100. FT4 was 11. The thyroid scan showed no thyroid tissue. So, Dr. Manisha, what is the plan here? What do we do next?
Thank you, Dr. Prateek. I think this is obviously a case of hypothyroidism with TSH so high and FT4 low. So we have to start the treatment as early as possible, because there is a window period of 14 days in which we have to start treatment, and treatment started beyond 14 days may have developmental and neurological sequelae. So we don't have to wait and we have to start the treatment immediately. The preparation which is used is levothyroxine, and there is no role of T3. And the brand which is started has to be, we have to stick to that brand, because there are differences between various brands. So we have to use the same brand throughout the treatment course. And the tablet form is available. The syrup forms are usually not stable. So tablet is given in small babies. Tablet can be crushed and dissolved in the milk and then given to the baby. The dose of thyroxine which is given is 10 microgram per kg per day for dysharmonogenesis and 15 microgram per kg per day for dysgenesis. And the timing of giving thyroxine is 4 hours after feed, or as far as possible, we'll try to have a difference between feed and the thyroxine tablet.
Okay. So this child was started on therapy. Then what happened is the repeat test showed that there was high free T4. And actually the dose was progressively reduced and finally the child was off treatment. So what happened here? How was this progression happening, Dr. Manisha?
So, Dr. Prateek, I think this child could be a case of apparent athyrosis, because when doing a nuclear scan, if we do a nuclear scan, either we can find ectopic thyroid, or there can be no uptake or increased uptake. In case there is no uptake, we have to do ultrasound and in ultrasound, if there is no gland, obviously it is thyroid dysgenesis and it will persist for lifelong. But in this case, the thyroid gland was there. There was a gland obviously found, and it can be eutopic. That is, thyroid gland can be found. The eutopic on ultrasound and no thyroid uptake can be because of either thyroid receptor problem or sodium iodine symporter defect, or there can be a antibody, thyroid blocking antibody, which has crossed the placenta and came to the baby, which is now causing hypothyroidism in the baby. So by 3 months of age, this antibodies will gradually disappear and the child may become normal.
Yes.
So this could be the cause.
So I think very important messages which came from you, Dr. Manisha, in this case was clearly that we need to start high dose. That is the problem, because often we see starting at around 12.5, 6.25, hit early, hit hard. If you're in doubt, start at 50 micrograms. So 3 kilograms, typically 50 would be the dose. Our aim is by the next time you do that, the FT4 should be in the thyrotoxic range. That's what we want to achieve. Now, scan, of course, is very, very important. But if it's not feasible, start treatment. Don't wait, as you very nicely said. And again, scan is not a foolproof thing. And you can also have these sort of cases which can be missed. So what are the key messages, Dr. Manisha, from your side for this?
So all absent uptake are not agenesis. We have to do ultrasound scan to rule out the apparent causes of athyrosis. And the key message is we have to start early, and hit hard.
Thank you, Dr. Manisha. So 4-day-old child, now with TSH more than 100, was labeled as dysharmonogenesis, started on LT4 at 50 microgram. At 4 weeks, it was noted that the TSH came down, but not fully. So TSH was 24, and FT4 has come to the normal level of 21. So Dr. Jyoti, what is happening here? Should we increase the dose of LT4 because TSH has not come down?
Thank you, Dr. Prateek. Here we are seeing in this case, free T4 and TSH is persistingly high, even at 4 weeks of treatment. Still, we shouldn't hurry to increase the dose due to reset hypothalamic-pituitary-thyroid axis, which will take some time to resolve. And so our target is to keep free T4 on higher side of normal, which may take few months. And free T4 levels are better indicator of adequacy of treatment in this setting. And the levels should be measured after 2 weeks of initiation of treatment and 4 to 6 weeks subsequently. This basically means that we should continue the same dose.
So after 3 years, when the child was reevaluated, it was noted that the child had delayed speech. So what was missed here, Dr. Jyoti?
So this is a case of dyshormonogenesis with delayed speech at 3 years of age. This gives us the clue that every case of hypothyroidism should be evaluated for other assessment, other things as well. We have to do X-ray to look for epiphyseal dysgenesis, and hearing assessment is to be done to see for the hearing abnormalities, as hearing abnormalities and dysharmonogenesis and hypothyroidism is pendred syndrome. And along with that, we have to even go for developmental assessment as well.
Yes, doctor. So the key messages in this case were?
So the key message in this case would be that reset hypothalamic-pituitary-thyroid axis will take some time to resolve. We have to initially titrate with the free T4 level, and hearing assessment is vital in such cases.
Very important message that do not chase TSH level, because if you chase TSH, you will become thyrotoxic. That's a big message coming from here.
Thank you, Dr. Jyoti. So now we move on to adolescent children. A 12-year-old girl with obesity. She came to the endocrine OPD. Her height was 156 centimeters, weight was 56 kgs. There were no clinical features of hypothyroidism. The TSH was done and it came 6.4. And this child was advised treatment. Dr. Sonal, was this a wise thing to do?
As the TSH is 6.4, you obviously think that this might require treatment. But in case, as already we had discussed in the previous module also, because of the obesity, to increase the metabolism, the hypothalamic-pituitary axis gets activated. And as a result of this, that is a high TSH, and which gives, so it is because high TSH is not the cause of the obesity in this child. It is the effect of the obesity. So we should not consider the treatment. So whenever you have high TSH, we must do the free T4 level. If the TSH value is more than 10, then you must start the treatment. If it is less than 6, there is no question of the treatment. But if it is between 6 to 10, then we must go for first free T4 level. If the free T4 level is low, then it is required in treatment. But if it is normal, but in this condition, I'm not considering the obese child, but any child who has high TSH with low free T4 and borderline TSH and low T4, we must see for the risk factors in this child. If the child is TPO positive, or some goiter is there, or there is a growth failure is there, in that condition, we must take the treatment. We must consider about the treatment. But if there are no risk factors, we must keep this child under follow-up.
Thank you, Dr. Sonal. So the key messages were?
Key messages is high TSH effect. The high TSH is the effect of the obesity. It is not the cause of the obesity, and you should not start the treatment if TSH is below 10. And if it is between 6 to 10 and the other risk factors are there, then we must consider about the treatment.
Yes, thank you. So the next child is a 10-year-old girl with poor concentration, poor scholastic performance. The height is 136 centimeters. The weight was 34 kgs. Now, when the TFT was done, it was seen that the TSH was 2.4, but the T4 was low, that is 60. Now, Dr. Seema, should we start thyronon therapy because the T4 is low?
Or should we consider central hypothyroidism in this? Because T4 is low and TSH is less than 20.
Thank you, sir. Thank you, Dr. Pratik. Now we have another case, 10-year-old child presented with poor concentration, and looking at the TFT reports, as there is a log linear relationship between TSH and T4, T4 is low. So TSH has to be raised. So is it really the case? Let us have a look on the normal T4 physiology. T4 circulates in the blood pool along with the transport proteins like albumin, thyroid binding globulin, thyroid binding prealbumin. And total T4 level is grossly dependent upon the level of these factors. In pediatric conditions, there are various conditions like nephrotic, chronic liver disease, in which if these proteins are low, this will be depicted as low total T4. Hence, we should, if the T4 is low, total T4 is low, we should always look at the free T4 level, which we did in our case. And it came out to be pretty normal. To be more sure that we are not missing case of any hypothyroidism, because it is a preventable cause of intellectual disability and causes much more harmful effect at the age of 10, like precocious puberty in girl. So TP also we did, which came out to be negative. Hence, for this patient, we need more evaluation for poor concentration. But for as far as treatment is concerned in the form of L-troxin supplement is not required. So the key message out of this case discussion is, while interpreting report, always look for free T4 rather than even ordering. Don't order total T4, order only free T4 and TSH and plan accordingly. Thank you.
Thank you. So the next case is a 12-year-old girl with lethargy. The height is 140 centimeters, weight is 36 kgs. Here the free T4 is very low at 6. The TSH is 12. And this child was started on LT4 therapy. So Dr. Manisha, was this the wise thing to do because thyroid is low, so we should start, or we should do anything else?
No, I think according as previously discussed by sir also, if FT4 is low, since there is a log linear relationship between TSH and T4, the TSH should be high. But in this case, TSH is below 20. So it is a case of central hypothyroidism. And the causes of central hypothyroidism, the most common cause is multiple pituitary hormone deficiency. So we have to do a MRI scan and do a anterior pituitary hormone assessment. So if we start thyroxine and if there is cortisol deficiency, as in a case of multiple pituitary, it will unmask the cortisol deficiency and child may develop shock. So it is very important to assess all the cases of central hypothyroidism with anterior pituitary functions and MRI scan. So in this child, there was low cortisol level and MRI scan shows empty sela, tersica. So we have to start hydrocortisone and then thyroxine. So the key message is low FT4 with TSH less than 20 is is central, and in those cases imaging has to be done and anterior pituitary hormone assessment. Most importantly, the cortisol levels has to be done. Thank you.
Yes, thank you. So next is a 12-year-old girl with growth failure. TSH is clearly more than 100 and FT4 is low at 6. So Dr. Jyoti, now how do we proceed with this child?
Thank you, Dr. Pratik. So this is a 12-year-old girl with growth failure with TSH of more than 100 milliunits per liter. So we have to start the treatment. Your timely initiation of the treatment is very important with oral levothyroxine. And LT4 is the preferred form of treatment, but there is no role of T3 over, no added advantage of T3 over T4. Dose is 100 microgram per meter square per day, as younger children require higher doses on a weight basis. And for this adolescent girl, so we can also start the dose of 3 microgram per kg per day. On the age basis, this would be started on 25% of the dose, and then gradual build up of the dose should be done over 4 to 6 weeks period. And the next thing is that the absorption of thyroxine is affected by food. This is very important message. So the drugs should be taken at least 4 hours after or 30 minutes before the meal. And along with that, there should be a gap with calcium, iron, antacid, because it impaired the absorption. So there should be a gap of at least 6 hours between the thyroid medication and these drugs.
So this same child was followed up for a year and TSH was 24, but FT4 is now 26. So now, Dr. Jyoti, do we reduce the dose because this child has high T4 level?
This is a very confusing picture, Dr. Pratik, as you said, that this child's TSH is also high and FT4 is high. Now, what will cause high FT4 and TSH? And this is a dilemma. Now we have been asked, the fellows are asking whether we increase, other persons say the FT4 is high, decrease. So what should we do, Dr. Jyoti, in this case?
Definitely, we have a dilemma in such type of cases, because I even had come across a similar case. So we should ask specifically about the adherence to the treatment. That is, levothyroxine is been taken by the child regularly or not. So this seems that the child has started taking levothyroxine just before coming to the pediatric clinic. So we have to ask specifically about the adherence. And dose adjustment is very important. If TSH is high along with free T4, that is also high, then we have to check for the adherence. And if TSH is high with free T4, that is low or normal, we have to increase the dose. And if TSH is low with high or normal free T4, then we have to reduce the dose.
I think this is a lot to do with the half-life of both FT4 and TSH. FT4 is a short half-life, TSH is a long half-life. So by the time a change in dose will have an effect on TSH, it will be 6 to 8 weeks. FT4 will be immediately effective. That's why we say do FT4 before you take the tablet. Now, if somebody is taking tablet for 6 days and he was not taking any medicine, maybe he has taken 2 tablets every day. That's why his FT4 has gone up, but TSH might have been 100. It has become 26, but will take time. So it's again the reset axis. As we talked about in that neonatal case, the same thing is happening again. So understanding physiology really helps a lot in that perspective. The other big message which was there was a gradual replacement. So I think that's for the big point which Dr. Jyoti talked about. So maybe a key message is, Dr. Jyoti, from your side.
So gradual build-up of the dose should be done over 4 to 6 weeks time, and timing and adherence to the drug is very important while treating such case of thyroid disorders. Thank you.
Thank you, Dr. Jyoti. So the next case is a 12-day-old child with irritability. We have been called to the NICU, and the NICU in charge says that this child has irritability, has lost weight, 600 grams. On examination, this child has tachycardia, a vacant staring appearance, and the thyroid profile was done, which showed high FT4 and low TSH. Now, an important history the mother gave that mother had Graves' disease and undergone ablation 2 years ago. So, Dr. Sonal, is it possible that the child has thyrotoxicosis despite the mother not even having a thyroid gland?
Yeah, because this obviously shows that child has lost weight also, and child has irritability, and child has tachycardia. So it is definitely, and proptosis but there is no proptosis, but this is and high T4 is there. So it is definitely a case of thyrotoxicosis. But now here the question arises that mother is right now not on any drugs. How come the child developed the thyrotoxicosis? So you must remember that that TSH receptor stimulating antibodies, they can cross placenta even if the mother has been fully treated with the disease. So it can cross even after that. So we always must ask the history to the mother whether if the child shows clear-cut signs of thyrotoxicosis. One important history of mother being treated for Graves' disease, we must ask for it. So we must remember that TSH receptor antibodies, they continue stimulating antibodies, they continue to cross the placenta even after the 2 years of the treatment. So this is definitely a case of thyrotoxicosis.
Key message is here, Dr. Sonal?
Yeah, key messages here is whenever patient has weight loss, tremor, and we must suspect thyrotoxicosis, and eye signs favors Graves' disease. And we hear that drug of choice is methimazole and radioactive iodine, and we must take the history in the mother when the mother has undergone any such treatment for Graves' disease.
Thank you, Dr. Sonal. So now we come to a 12-year-old girl who has history of weight loss and tremors. The TFT done shows a suppressed TSH and high FT4. There is a goiter, but there are no eye signs. What is the plan in this patient, Dr. Seema?
As the 12-year-old girl child presented with weight loss, tremor, and thyroid swelling, but eye signs still not present. Given that report of FT4 and TSH, this is clear-cut case of thyrotoxicosis. In this slide, showing various commonest clinical picture of hyperthyroidism or thyrotoxicosis. Weight loss is there, hyperdefecation is there. There will be fine tremors. Eye sign, lid lag, chemosis, proptosis is there. Why? When we'll diagnose proptosis, when the upper sclera is present, as showing in this picture, there will be periodic paralysis and polyuria. The etiology of these things in the hyperthyroidism is because of the sympathetic surge present in the hyperthyroidism. So how we'll plan? We should go for nuclear scan, but if the eye sign is present, like lid lag and proptosis and thyromegaly is present, we should can avoid the nuclear scan. In our case, the thyroid scan we did showing increased uptake. These are 3 pictures of thyroid scan. First one is showing solitary nodule. Second one is multinodular goiter. In our case, this is diffuse enlargement of thyroid swelling like a butterfly shape. So this gives us a clue of Graves' disease. However, if the nuclear scan is showing decreased uptake, this will go towards thyroiditis. And on examination, if the palpation, if tenderness is there, then it is subacute thyroiditis, and if the no tenderness is there, then chronic lymphocytic thyroiditis. This patient we diagnose is Graves' disease, and we will start antithyroid drug methimazole to control the sympathetic drive like heart rate, tachycardia, CHF. We will start beta blocker, most probably propranolol. But if the patient is having asthma and all, we should start metoprolol and radioactive iodine. So the key message after this patient discussion is, if there is a tremor and weight loss, we should think of thyrotoxicosis. If eye signs are present, then think of Graves' disease, and treatment of choice is methimazole and radioactive iodine depending on the age and various etiological factors. Thank you.
I think that was a very wonderful discussion, Dr. Seema. This key message which comes out is that clinical examination is very important. What is the most common cause of thyrotoxicosis with eye signs? What is the most common cause of thyrotoxicosis without eye signs? So Graves by far is the elephant in the room. If your T4 is very high, above 100, if your eye signs are there, if you have goiter, it is Graves. So 90% it's Graves. In children, thyroiditis is less common. On the other hand, if you have a tenderness, if your FT4 is marginally elevated, you have no eye signs, then do a scan. Don't do a scan in everybody because it's not required. The other big message which came out was a solitary nodule with having thyrotoxicosis. So in that case, you have to really think of it. Do a FNAC if required, unless, of course, there's a frank thyrotoxicosis, and consider a surgical treatment. That's a big message compared to the adults which comes from there.
So the next case is a 8-year-old boy who is presented to the OPD with the neck swelling. Dr. Manisha, now how do we proceed with this clinical picture?
So a neck swelling near the thyroid region can be 4 types can be there. Either it can be a thyroglossal cyst, or it can be ectopic thyroid adenoma, or it can be malignancy also. So if the benign features if the swelling is benign, that is, it is not attached to the underlying structure, if it's slowly progressive and is smaller than less than 1 centimeter, is most probably benign. So Dr. Pratik, can you tell me what are the other features like movement with the deglutition and movement with tongue?
Yes. This swelling was a midline swelling. It was cystic in consistency, smooth surface, and it was moving with tongue movement as well as deglutition. So, since the swelling, as told by Dr. Pratik, is movable and is cystic, and it moves with movement with the tongue and with deglutition, it's most likely thyroglossal cyst. Thyroglossal cyst is the remnant of thyroglossal tract, which is the tract through which thyroid tissue descends from the pharyngeal floor to the thyroid cartilage. And in most of the cases, it involutes after the thyroid comes to its original place. But in some cases, the thyroglossal tract can remain and in the form of thyroglossal cyst, may present later in the form of swelling and pain. Since thyroglossal cysts are more prone to infections, it is better to operate, and a surgical excision is required. Yes. Thank you, Dr. Manisha.
Thank you.
So now we have a 10-year-old girl with a thyroid nodule. This child was evaluated by a physician, was initially euthyroid. Even TPO was done, which was negative, and the child and the parents were reassured. But what happened after 1 year, that there was rapid growth. So, Dr. Jyoti, what really happened here? What was missed?
Thank you, Dr. Pratik, for sharing such an interesting case. This is a 10-year girl with thyroid nodule with euthyroidism. So for this type of thyroid nodule, so we should not take it granted that it would be, or it is going to be a benign lesion. So we should have a detailed workup. So we should have we should go for careful assessment of the thyroid nodule is essential. First, we have to focus on the duration, and the course of the swelling is very important in this case, and family history is very vital, as we have to inquire about malignancy in the family, or any history of thyroidectomy in the family is there or not, or history of radiation exposure is also very important. And most importantly, we have to go for the thyroid examination, the size, surface, and is the nodule fixed to the underlying surface, and associated lymph nodes are there or not. So hard and so the pointers to the malignancy is the size, which is more than 1 centimeter, which is there in this case, and if it is fixed to the underlying skin, and if the palpable cervical lymph nodes are there, then that this suggests that there are chances of malignancy is there. And so we should further go for investigation. Ultrasound and FNAC has a crucial role to play. So the key message is thyroid nodule points toward malignancy in 10% of the cases, and ultrasound and FNAC has a crucial role to play.
So, Dr. Pratik, I think FNAC is a very, very important message which has come out from this overall presentation. When you do a FNAC, what are the precautions you will take in a child whom you are doing an FNAC?
So we need to see the size before ordering an FNAC, and need to see whether we are taking the proper cell, where we are taking it from. That is also an important point.
So I think that's a very, very important thing to remember, that size is a criteria, but in children, as Dr. Jyoti has very nicely said, it's not just 1 centimeter as a standard criteria. For a younger child, thyroid is smaller. So even at smaller size, you can have a problem which may happen in that perspective. So it's vital that you actually look at other features, especially the ultrasound features, which become very important in that perspective, and that can really cause confusion in certain changes. So the ultrasound features that you should look for include microcalcification, area of solid and cystic area, which may be there, area of necrosis, which may be there. There can be many of those issues which can cause a confusion and problem in that perspective. So that's very, very important. The other big issue is that we, not we in the sense of American Thyroid Association recommends that it should be a ultrasound guided FNAC in children with nodule. That's a very, very important message, because often you will miss out on that perspective. And very importantly, you need to know that there is a standard criteria, which is the NIH guidelines, which classifies into different aspects on that perspective. So I think what we have done is that we have really gone through the entirety of the thyroid disorders in a lot of detail. And we started right from the dilemmas in terms of congenital hypothyroidism, the importance of doing both FT4 and TSH, importance of looking at thyroid scan, looking at associated abnormalities like hearing abnormalities in that case, crux of primary hypothyroidism in which treatment should be slow and gradual, while congenital the treatment should be very, very rapid and aggressive in that perspective. So I think we'll see if there are any questions, and maybe if there are any discussions with the panelists, because we have really stuck to the time. So very nicely done by Dr. Pratik that we have really been on absolute time in that perspective. So we've got some time for discussion as well. There is a question which is there from Dr. Edel, who is asking about, in obesity, what is the cutoff level for hypothyroidism? So I think this point was already discussed by Dr. Sonal. I think I discussed it. Dr. Sonal, what is your discussion on that point?
Yeah, if it is about 10, then definitely you must consider starting the treatment. Yeah. If it is between 6 to 10, then you may not start the treatment, or you may go for the FT4 level and free T4, FT4 level. And if depending on if there are signs are there, like family history is there, goiter is there, growth failure is there, in that condition, you should start the treatment if it is between 6 to 10.
I think that's a very, very important message to consider. And there are a couple of new studies which have come up, which are quite relevant in that perspective. There's a recent study which was published in the Journal of Endocrine Society, just this issue of the journal, which looked into the same issue. What happens to children with obesity who come to us with a marginal thyroid? What happens to them? And what they found, that if your levels of TSH are more than 8.7, if you have a goiter, and if you have a strong family history, there is a chance of progression. So this 10 cutoff is very good. So 8.7 is what they found in one study, but 10 is a more generic cutoff. The second study, which actually was done by Riddhi in our setup, was in around 400 children with obesity. We looked into the same issue of subclinical hypothyroidism, whether this subclinical hypothyroidism were doing something or not. Now, the message is very clear that less than 10 don't treat. But what we found, that children who had a TSH which was between 6 to 10 had a much higher likelihood of having non-alcoholic steatohepatitis as compared to those whose TSH was less than 4. And when we did a regression analysis, what we found out was that it was the TSH which was a more important determinant of SGPT levels as compared to the BMI or the body fat or other aspects. What we need to understand is that there may be certain situations in which there may be confusion in that regards, and we need to look into that. But for very clear message, do not treat less than 10 in that perspective. The other question which is there from Dr. Sara Mohammed is the cause of elevated TSH in obesity. So again, I think this was discussed by Dr. Sonal, so you can maybe shed more light on that, Dr. Sonal.
Yeah, it is because to increase the metabolism, to compensate for that, there is hypothalamic-pituitary axis is activated, and as a result of that is increased TRH, and it which in turn leads to increased TSH.
So as discussed very clearly, that body is trying to shed energy, like you want to burn energy. So that's why it says, okay, let's go off and start TRH. The fat becomes more, leptin becomes more, it goes to the brain and says, okay, TRH goes high. But then it realizes that if I burn more thyroid, I will be burning bone, I will be burning muscle. Fat will not come down. So then it stops at that level. So this TSH elevation is related to the fat. It's a sort of a defense mechanism, which is stopped because it's going to go do more harm than any good in that perspective. Next one from Dr. Manar Ali is that in patients with high free T4 and high TSH, we might think of thyroid hormone resistance. I think this is an important message. So the thyrotoxicosis part was taken up, I think, by Dr. Jyoti in that regards. Yeah. So how do you interpret somebody who has a high FT4 and a high TSH?
Thank you, sir. If there is high TSH and high free T4, first of all, we have to think of the adherence to the treatment is there or not. First, so if the adherence to the treatment is not there, then we have to think of the other causes.
So Dr. Seema, what do you think if you have a child who is not on treatment and has a high FT4 and a high TSH? First of all, how likely is it? And then what should we do in that regard?
The thyroid receptor hormone resistance is very rarely. So basically, if we think of the thyroid receptor hormones are not acting properly, there is some genetic mutation or something like that. So we will evaluate accordingly. We will do all nuclear scan, ultrasound.
Yeah. So I think the big message is that if your FT4 is high, TSH should be 0. If you have a detectable TSH with a high FT4, there are only two theoretical possibilities. One is the pituitary resistance or resistance to thyroid hormone, and second is TSH secreting adenoma. Now, TSH secreting adenoma is exceedingly rare in children. It's very rare in adults. It's absolutely not there in children. So I'll say if you have a high FT4 and not even high TSH, a TSH which is detectable repeated, often you will find the level is normal in that perspective. One situation I've seen this sort of a picture is in somebody who is recovering from an illness. We didn't talk about the sickness and the effect of thyroid on sickness. In sickness, what body does is that it tries us to conserve our energy. So it doesn't want to waste your energy. It converts T4 to T3, which is the inactive form. So the monodeiodinase 2 is active. So you're shunting away your thyroid from acting. But once the recovery happens, there is suddenly an increase which happens in MDI1 activity. And in that situation, your FT4 may go up. So in somebody who's recovering, you may see a bizarre level of levels. You may see a low T4 and a normal TSH, which will go up to high TSH and a high FT4 also. So again, that will be a situation. But I would say in 99% cases, if you have a FT4 with a detectable TSH, it would basically mean that there is an error in the lab. you have to do a repeat testing from that perspective, and that's how it will go on that perspective. But this is very, very important from that regards. Now, Dr. Hamilton is asking, it's important in the case with goiter more than 10 mm that the classification of tirades be used in the evaluation. So I think that's important from that perspective. Yes. So ultrasound is very important. We always say that in children, the risk of malignancy in a solitary nodule is roughly around 8 to 10%. Earlier, we used to say 15, 20%, but now we say 8, 10%. So 1 in 10 child who has got a level, basically, who has got a solitary nodule of thyroid, you're worrying about malignancy. So what do? You look at the size. If the size is more than 2 centimeters, you have to do FNAC in everybody. If it's smaller, go for ultrasound. And then in ultrasound, there are various criteria which are available, which talks about the calcification, the vascularity, and how the size is, how there is internal echoes. We decide whether you need an evaluation. So the tirades classification is regarding that. So I think that's a bit beyond the discussion what we are trying to do in that regard.